Sbeih. I'm a neurosurgeon, and we are transmitting live from Amman, from the Farah medical campus here in Jordan. This backdrop slide is for me to say something that all the presidents of the World Federation of the Neurosurgical Societies, they visited Jordan. We are on the map of neurosurgery worldwide. Just to mention a few, Jack Roche, and Professor Sami Iblows, Peter Black, and others. The topic for tonight is germinoma with bilateral location, bifocal. So we're talking about germ cell tumors, which arise from the embryonal rests of germinal cells. These are the totipotent cells from which we are produced. So germ cell tumors, we will talk about seminoma from the testes, or this germinoma in the ovaries, or germ cell in the erythroperitoneum and tumor intestinum, and also intracranial germ cells. So intracranial germ cells in general, they affect pediatric young adult group. They are rare. They are 1 to 3% of all pediatric brain tumors. And the Western series is less than the Asian series. Asian series is more. The intracranial germ cells are either true germinomas or non-germinomas. The commonest is germinomas, 2/3, 1/3 in non-germinoma. These are potentially malignant, these are malignant. So we speak to get rid of the non-germinomas. These include the yolk sac tumor, or the old name, the endodermal sinus tumors, embryonal carcinoma, choriocarcinoma, teratoma with its types, mature, immature, and malignant, and the mixed germ cell types. Examples of these non-germinoma germ cell tumor: yolk sac tumor, embryonal carcinoma, choriocarcinoma, teratoma with 3 types, which we mentioned, the mature, immature, and the malignant transformation, the mixed germ cells, and recently they added this new type of panel type of pathology that was described in this paper. Let's concentrate on pure germinoma because our case is a pure germinoma. Germinomas, as I said, they are 3% of all pediatric brain tumors. The peak is 10 to 12 years. But look that 90% of cases are below the age of 20. So it's mainly pediatric young adults. Germinomas are associated with syndromes. Klinefelter, which, as you know, is when a male has 2 or 3 X chromosomes. So he's a male but with feminine characters, with nobody hairs, with small testicles, etc. And they are liable to get germinomas. Or Noonan syndrome, which is just the same, affecting the growth and affecting so many organs development, like heart defects and etc. And Down syndrome. So germinomas, locations, the commonest is in pineal, followed by the suprasellar, and it could be in both, bifocal, in the pineal and suprasellar. So the commonest is pineal. And you may get it in other locations, which we don't think of, like third ventricle, lateral ventricle, fourth ventricle, basal ganglia, thalamus, and spinal cord. Let's go through them. Pineal germinoma. Germinoma in the pineal. This is the commonest type. We don't know the reason, but they are common in males, the pineal ones, while the suprasellar are common in females. Suprasellar, common in the females, affecting the stroke, the hypothalamus, like you can see here. And this is a word of warning: any pediatric patient with DI, he must have MRI. Don't say that this is usual for a patient, young patient, to drink lots of water and pass lots of urine. Must have MRI. This paper from China, 2010, the intracranial germinomatous, suprasellar germinoma. I have a similar case like this, which turned out to be immature teratoma in Bahraini girl. So you can have double lesions in the supracellular, in the pineal, and this is very much pathognomonic of germinomatous. So tumor developing in two sites. It is not actual spread of one tumor, developing in two sites. Different names for these double lesions: simultaneous tumors, synchronous tumors, sequential tumors, double tumors, multifocal or bifocal.
And you would have to remove both when you go in?
No, not necessarily. This paper about the supracellular pineal from Argentina, they conclude that it does not indicate dissemination. There are two focal tumors. So you can also get it in the basal ganglion, unilateral or bilateral. And who would of us, one of us, think of a basal tumor like germinoma? So unilateral or bilateral in the basal ganglion, which is not a common site for tumors. These are basal ganglion germinomas. Sometimes they are big tumors, sometimes they are subtle tumors, sometimes with calcification. These are basal ganglion germinoma. The typical presentation for a basal ganglia, especially in a child, poor schooling. This is the commonest presentation. Cognitive disturbances, personality changes, dystonia is very common because you are hitting the basal ganglia. And of course, hemiparesis because of the close proximity to the internal capsule. So basal ganglia germinoma, this paper from USA 1999, you can see that it just increase or hemiatrophy of that area and then developing into a tumor. Findings in germ cell tumor arising from basal ganglia. Again, you just find little change that you have to be aware of. Don't dismiss it as trauma, because this will develop into a large tumor. This paper from Canada, from Toronto, Sick Children's Hospital. Again, basal germinomas. You can see the changes here and there. Look at this very subtle change here. Or very big change like this here. Again, basal ganglia can occur in adults. They are common in children. They can occur in adults like this. Different types of basal ganglia germinoma. This paper from Japan, 2004, again subtle changes. And they are always associated with atrophy in that side and of course corresponding hemiparesis. So you have to look for early imaging findings in these tumors. This is the earliest you can see. You can see that there is atrophy in the basal ganglia, and this will develop into a tumor if you are not careful. Same here and here. Germinoma basal ganglia from Seoul, South Korea, 2010. This is a progression of this early change into this, into this.
How long?
In a 1 year time. Yeah. They are potentially malignant. Yes.
Because 1 year.
And this is the PET scan to show you the uptake. This is very helpful to look at if you are in doubt. They can be in the lateral ventricle, as I said. You may easily miss this as choroid plexus tumor, while it is a germinoma. That's why we keep hammering the idea of differential diagnosis. You just cannot think of one or two pathologies and just walk. You have to think much deeper than this. They can occur in the medulla oblongata, inside the medulla. This paper from USA, from Boston. Again, fourth ventricular tumor within the fourth ventricle. This is histological proven from Japan. Again, the value of PET scan on these tumors, you can see the uptake. We are not using PET scan a lot. We should use tractography, we should use spectroscopy and so on. Yeah, sure. We have it, but we don't use it. It can affect the cerebellum itself. Cerebellar germinomatous paper 2016. recent paper. Can affect the spinal cord, intrinsic, intramedullary spinal cord tumors from the radiology journal from Japan. And here is the warning about these markers. In germinoma, the AFP, alpha-fetoprotein, and the beta human chorionic gonadotropins are negative. So if you have a double lesion in the pineal and in the supracellular, and you have AFP negative and BHD, this is most likely germinoma. While in the others, in the non-germinoma, they are usually positive. Okay? So this is a very important marker. Are there staging of germinomas? Yes. Starting with 0, when you have just a tumor with no metastasis, or 1, if you have just positive cytology in the CSF, M2, if you have intracranial metastasis, and M3, if you have a spinal metastasis. So if you have a case of germinoma, please do total spinal MRI, so that you will know whether there is metastasis or not, so that you can stage your tumor properly. Can they metastasize? Yes, look at this. Metastasis inside the cranium or to the spine. What is the treatment of these germinomas? Controversial, but basically main landmarks. Surgery. In germinoma, you may not do surgery if you are sure, but in the others you have to do surgery to debulk the tumor as much as you can. Chemotherapy is there, radiation is there. This is very important paper. It says, is histological verification crucial for therapy? This is from Holland, Netherlands, 2007. So if you have a supracellular and pineal location like this, with normal alpha-fetoprotein, normal PHCG, the only possible diagnosis is germinoma, and you can start with low-dose radiation.
Without biopsy.
Without biopsy. What is the current management? They usually come with antibiotics. And what is the Arab disease and the underdeveloped countries disease is shunt. This is crime against humanity, and I will not stop fighting against it. We teach residents to do shunts unnecessarily. So the resident would come with reputation of doing shunts and division of shunts. The best shunt is no shunt. It is universal everywhere in the world except in the Arab countries and in the underdeveloped world. You can't just leave this tumor and put a shunt. You just can't. This is a crime. Or this tumor and put a shunt. Now this is everyday practice in Jordan. So what about radiochemotherapy? Germinomas are responsible for both, more for radio, more than chemo. So radiotherapy, they are radiosensitive. Look at this. 5-year relapse-free, 90 to 99%. 5-year overall survival is 85%. So it's very good. Let's see this. This is chemotherapy prior to reduced dose. What about giving chemotherapy and then give low dose of radiation? They have tried it in USA and they say it's useful. This is the one case, double lesion, and this is 6 months after radiotherapy alone, without surgery, without biopsy. Another case, 9 months after radiotherapy alone.
How do you diagnose it before?
As I said, because it is double and because AFB and beta CG are free. So you can be pretty sure that this is 100% a germinoma.
And you hit on both at the same time? Or
Yes,
you hit one at
yes, hit on both at the
Is
same
it
time.
whole Blair radiation or stereotactic?
We will come to it. 9 months after radiotherapy alone. These are papers, not mine. This germinoma radiation only from the German cooperative study, 83 to 93. Just radiation only. Craniospinal radiation, 36 grays. Local boosted radiation, 50 grays. They used it in 6 patients and reported 94 overall survival.
5 year?
Yes, 5 years. However, this is the warning, radiation only requires higher doses and larger fields with high risk of long-term sequelae, especially in a child. So everything has something to it. This is another paper, 2005 from Canada, from Toronto, limited field radiation for bifocal germinoma. This is the paper also from Taiwan. Germinoma, can we lower radiation dose without chemotherapy? And they said yes, give just 30 degrees. So long that high doses of radiation cause damage, give low dose, give 30 degrees. There's something called extended focal radiotherapy. And this is your answer, Mahmoud Khatib. This is radiation to the ventricular system. This is called extended focal, different from craniospinal. Again, this is from Taiwan, paper from Taiwan, published in Child's Nervous System, 2008, about 7 patients. They just give them focal, including ventricular system. What about chemotherapy? And just good timing, Ala. Chemotherapy for germinoma, it's less response than radiotherapy. Radiotherapy for germinoma is better response. Again here, 2 years overall survival is 84%, so it's not bad. Germinoma, chemotherapy only. First international cooperative study, chemotherapy without radiation by the use of carboplatin, etoposide, and bleomycin. Published 96, 45 patients, 1/3 were free of relapse. So people are trying radiation alone, chemotherapy alone, but at the end of the day, the multimodality is the best. This is the paper about chemotherapy only. This is the second international cooperative study, published 2004. Use of cisplatin and cyclophosphamide, 5-year survival 75%, which is good. Again, they admit that chemotherapy alone is less effective than radiotherapy. So, multimodality is the best treatment. French study, experience of French society in 1997, and the Japanese study, 2004, they use chemo and radiotherapy. So combined chemo and radiotherapy, the Japanese experience, 2001, using the cisplatin and radiotherapy, 24 days, low dose. So the aim is they use chemotherapy, and this would allow them to give low dose of radiation. As you know, we are treating children here. Again, induction chemotherapy followed by low dose radiotherapy. So many papers, now it is well established. You give chemotherapy, you give low dose radiotherapy. This is the best combination. From Japan, Journal of Clinical Oncology, using these drugs and small dose of radiation. This is again germinoma optimal treatment strategy. From Japan, Journal of Neurosurgery Pediatric, chemotherapy followed by low dose radiotherapy. Chemotherapy prior to radiation from USA 2010. And this is a very interesting paper by Murray from Cambridge, 2013, the third International CNS Germ Cell Tumor Symposium. They asked the delegates to say what is their treatment, and they say they should receive radiotherapy for the ventricles, for the craniospinal, and chemotherapy to reduce dose of radiation. So, period. Chemo, and then followed by radiation. So, germinomas are curable in most of the cases, however, recurrences may be observed many years. So, again, the motto here is don't treat the patient and let him go. We have to follow him very, very close, even if it is a germinoma. So, let's look at these recurrent ones. They recur. Look at this. This is the radiation field taking the whole ventricle. The recurrence occurred outside it. So this is something to remember. Again here, it's outside it. The radiation was given for the ventricular system. The recurrence was outside the field. Like here, it's outside the field. Many years after finishing. So they can metastasize. Yes, potentially malignant, and here they are metastasizing to the external ear. Can they transform into pure malignant? Yes, they can. Germinoma transforming to malignant. 2010 from USA, again from Massachusetts, Boston. You can see the recurrence. So, we have given you an idea about germinomas in general, and the germs in tumor in general, germinoma in particular, because our case is a germinoma, and we discuss this clinical, radiological, operative, pathological correlation. I've sent you this to advertise about this lecture. This is the pictures before, and this is after. This is the histopathology. This is just a brief introduction. Our patient for tonight is a 16-year-old patient from Iraq, and this goes back to 2013. Very interesting story, and very sad. When she became 10 years old, her family started to know that she is not growing like her peers. She has short stature, no breast development, and no pubic or axillary hair, but she wasn't treated until 8 months before admission, when she was 16. So you lose an endocrinologist, and endocrinologist can tell us you cannot treat dwarfism after this, when the physics close, which is usually at the age of 10 to 12. So she had a growth retardation due to growth hormone deficiency, which did not happen as form of treatment unless she became 16 years of age. That shows you how backward we are in medicine and we are evolved. We have to stop bragging about our progress. We should be dealing with our mishappenings.
Don't they usually screen them at 8 years old, to Shahid? Don't they usually screen
They
for
don't
growth
examine them
hormones?
to have
No,
issues.
This was an Iraqi girl, remember?
Yes,
Yeah.
yes.
This
Well,
was in Iraq.
I mean, ask also any pediatric endocrinologist here, they can tell you horrible stories.
Ibrahim Marwan is asking me, do we screen these? The
Yes.
screen is the growth chart. You know, once you
Yeah,
see
exactly.
the growth chart.
So don't you usually take action at 8?
They don't examine.
You have to examine.
They start examining patients. They just do x-rays and that's it. I mean, what can you do in a clinic seeing 200 patients within 3 hours? If you just want to say hello, hello,
But
hello,
the same
you have
happens
to-
when they have two. It's an attitude.
It is also an attitude, yes. So, recently, and that's what brought her, she started complaining of headache. And were very severe 15 days prior to admission. Very severe. Frequent vomiting. Polyuria, polydipsia. Drinking 3 liters a day. And 2 liters at night, 5 liters.
Whatever it is.
I remember one girl like this who came with cryopharyngioma. She went to the endocrinologist and they said, he told the family, it's good, your child is drinking. So she had there, because of the headache and the vomiting and everything, she had this CT scan. What did they want to do?
Shunt.
Somehow they just managed to escape and they came our way. So examining her, she is maldeveloped secondary sexual features for a 16-year-old. She was cachectic and pale. The last comb scale was 14 over 15. Cranial nerves intact. She had papilledema. She had some motor weakness. And basically her CBC, bleeding time, kidney functions, liver functions were okay. However, in the pituitary function test, you can see LH is low, FSH is low, prolactin is okay, p-testosterone is low, free T4 is low, and cortisol is normal.
Her protein was high as well.
And this is her urine analysis. So we did see to the endocrinologist at that time, Dr. Nadal Al-Khatib. I asked him to come here now. Dr. Khatib is the endocrinologist who's seen her. And what did he have to say? Patient has long history of anorexia. She looks pale, semi-conscious, no secondary sexual characteristics, hypogonadism, generalized bone tenderness suggestive of osteomalacia, history of polyuria, polydipsia, thyroid function test is normal, the renal axis is intact, patient electrolytes showed hypernatremia, compares diabetes insipidus. Images, may I call upon Dr. Ahmad Athami to tell us about the images?
مساء الخير. This is the axial MRI T1 rated without contrast for the same patient. You can see there is a huge mass lesion occupying almost all the right frontal lobe with some signal void, which mostly due to calcification. The lesion extended downward to obstruct the foramen of Monroe, causing obstructive hydrocele at the level of lateral ventricle. Next. Also T1 weighted without contrast. You can see from down to up. This is the tumor extending upward, reaching the septum lucidum also. Post-contrast, this axial T1 weighted post-contrast, you can see there is almost heterogeneous enhancement with signal void, mostly due to calcification. The lesion extending into the foramen of Monroe, obstructing. There is no evidence of extension into the brain parenchyma, but there is some edema here. Is due to acute obstruction. T1 weighted, also post-contrast, you can see there is an extension of the tumor into the right cavernous sinus. From down to up, this is the cavernous sinus. This is the tumor in the right frontal lobe. Tumor post-contrast, reaching the septum lucidum with some cystic changes and calcification. T2 weighted, this is showing the tumor. The tumor has multiple cystic changes inside, large one, extended downwards. This is the edema, frantic edema due to acute obstruction. T2 weighted from down to up, almost the same finding with the edema here. This is, I think, flare sequence, the tumor touching the septum lucidum. Coronal view was contrast. Also, you can see the tumor is a huge one, reaching the parasellar, and there is some calcification here. Till now, the differential diagnosis, there are 4 differential diagnoses. The most important, this is another, I think this is another tumor extending from suprasellar, occupying the third ventricle, obliterating the optic chiasm recess and the this is, I think, infallopian recess. This is the pituitary gland. There is no right signal within the posterior neuroepiphyses. Sagittal view, different levels. You can see the tumor, cystic changes and calcification, and this is the pituitary gland. Also, multiple level, and sagittal view post contrast also, the same findings. T2 weighted, you can see the tumor, huge one, here affecting the stalk and infundibulum, and I think also there is no bright signal within the posterior neurophysis. Angio, you can see the angio closely normal, vertebral basilar, internal carotid, middle carotid, middle cerebral artery, anterior cerebral artery. Ibrahim, MRV, you can see this is the superior sagittal sinus, this is the stress sinus, vein of Galen, transient, and this is the angio also. Mostly normal.
So there is really not any kind of vascular involvement in this?
No, from the angio. Last one. The differential diagnosis regarding the lateral ventricle and the frontal horn, there are 3 to 4 differential diagnoses. The main one is the central neurocytoma, almost the same appearance, but the difference is the age, is about 20 to 40. The second differential diagnosis is metastasis. The patient didn't have any history of tumors. The third thing is subepidermal astrocytoma, which is common in tuberous sclerosis. It's about 10 to 15%, but in normal population is then 0.5. The last one is subependymoma. The subependymoma, first of all, does not enhance as this lesion. Second, fourth ventricle more common. And the suprasellar tumor, differential diagnosis, there are 3. Craniopharyngioma, which is heavy calcification. The second one is chiasmatic hypothalamic glioma. This is almost identical to this tumor. Could be the biocystic astrocytoma, could be a biomyxoid type 2. I think metastasis is the last one.
Would you also think regarding the binary tumor of a binary tumor like pineocytoma or binary parenchymal tumor of intermediate differentiation?
Wait,
Regarding the binary site, the binary location.
Sure, you should.
Yes, you have to look, but
Yeah.
there's no tumor here.
Yeah, so isn't it among the differential, radiologically at least?
Yes, it
Yeah.
is.
One point I want to emphasize that there are 3 tumors or 4 tumors can involve the pituitary, the suprasellar, in addition to the pineal body. One is germinoma, second is lymphoma, and third is metastasis, and rare is retinoblastoma.
I just want to add that this arching of anterior cerebral denotes that there is hydrocephalus, and for the old neurosurgeons, they did not have CT, MRI, they used to count on this phenomenon of high arching of anterior cerebral to know that there is hydrocephalus. So the differential diagnosis is varied, and I'm putting my cases here. These are not cases from books, these are actual cases of mine, and the histology is verified. This one's a pilocytic astrocytoma. Astrocytoma grade 3, JVM glioma, central neurocytoma. This was a girl from Iraq. Sarcopendymoma, which is different from ependymoma and different from tuberous sclerosis. I think we presented the Jordanian family under this roof with the 3 kids having this tuberous sclerosis. Germinomatous can be totally, exclusively within the ventricular system. Peanut, metastasis. So which approach I would choose for this patient? Now I know it is bifocal, but again this is a huge tumor causing hydrocephalus, so I have to do something for it. Either you go transcallosal in the midline, or you go transcortical. Because the tumor was mainly on the right side, so I opted to go transcortical. Some anatomy here. Let me close this. So if you will not go interhemispheric through the corpus, you go through the ventricle itself, like this. This is where you go. Usually you choose either the sulcus between the superior and middle frontal gyrus or the middle frontal gyrus. So you go like this. This is the so-called triangular flap which I use. This is the coronal suture. So you have to be familiar with the anatomy of the ventricular system. How many of our neurosurgical residents are? Very, very, very few. Because what he knows is just to put a shot and do a disc or evacuate the subdural hematoma. So this is the relationship of the ventricular system, with the thalamus, with the caudate nucleus, with everything that you need to know. And I always asked in the exam, how far is the foramen of Monroe from the internal capsule? The answer is less than 1 millimeter. So this is the corpus callosum, this is lateral ventricle, this is foramen of Monroe. This probe is going through foramen of Monroe, so we have 2 foramini of Monroe on each side. And Monroe is a man, not a woman. So this is the corpus callosum, this is the internal cerebral vein. So have to be careful. If you damage internal cerebral vein, if you damage the thalamus-striate vein, patient either will have hemiplegia or die. So there's no joke here. This is coronal anatomy. The ventricle, you will go this way into the ventricular system. You have the caudate nucleus, you have the thalamus, caudate nucleus, basal ganglia, internal capsule. And that's what I meant here. Internal capsule is less than 1 millimeter from foramen of Monroe. You have to imagine where is the head of the caudate nucleus and how it rotates around the thalamus. So this is the head of caudate going down. Caudate around the thalamus. And this is when you open both ventricles, the right ventricle, the left ventricle, the septum, foramen of Monroe on the right, foramen of Monroe on the left, the thalamus-striate vein, the septal vein, joining to form the internal cerebral vein. So the thalamus-striate with septic, formal intensive vein. Damage this, it's the end of the patient. So this is the loop of the third ventricle with two cerebral veins. We got the consent to have the surgery, and as I said, it has to be detailed as such. The flimsy piece of paper that people count on the management, and Dr. Morgan can allude to this, is no more acceptable. Qanun al-Musharat Tabi has been activated. If you don't write this, you'll go to jail easily. Stop just attending, say that I agree to have the surgery and so on, the 2 words or 2 sentences. Have to mention everything. Am I not right, Dr. Morgan?
Yes.
So, as we were preparing, patient had a dramatic sudden deterioration in her level of consciousness with anisocoria, fixed dilated pupil, all of a sudden, within a matter of minutes.
Pre-surgery?
No, no.
During
That's-
surgery?
We were preparing for surgery, doing investigations, blah, 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 and she just went off completely with fixed dilated pupil. What to do? Don't put a shunt. Because this is an excuse. Oh, it was late at night and the patient was going off, so we had to put a shunt. Ridiculous. You can put external drainage. It is because you don't know how to do the surgery that you are doing the shunt. It's clear. 1 + 1 = 2. It is for short-sighted surgeon, for the third-class mediocre surgeon who puts shunts for these cases. It's very easy. So we got the anesthesia. It was an emergency, so we were running like anything. So let's see the surgery. And again here, some people might put external drain. Again, this is sometimes as dangerous as the shunt itself. You just go for the tumor, try to open the foramen more as much as you can. So this is the cortical incision on the right side, in the middle frontal gyrus, and going into the ventricle, and this is the tumor.
So you go right into the ventricle?
Right into the ventricle, right into the tumor. There is no ventricle, it's closed.
But there is no brain tissue in between?
There is, but you choose where you go.
Okay.
So you start removing the tumor, and as you proceed, you will find the brain is getting laxer and laxer. So this is the tumor, and the white stuff is the ventricular lining. Very vascular tumor. So this is the septal vein, this is the tumoroid vein, this is foramen mondo here. Still there is a tumor. So I'm relaxed, foramen mondo is open. And I just want to concentrate on the tumor. I'm pulling it laterally to see the foramen mondo. I'm pushing it medially to see the relationship with the caudate nucleus. Again, a word of warning for residents. Caudate nucleus may look like a tumor. It's granular and it has a color. You may miss it for a tumor. It's just the experience which makes you not damage it.
Was it encapsulated brain? Or was
This was barely encapsulated. So you do the excision, and the idea is not to take a biopsy. The idea is not just to open the foramen mondo, the idea is to take as much of the tumor as I can, 90%, 99%, 100%. The idea of biopsy and radiotherapy is criminal, to say the least. And it is a common day practice in the Arab world and developed countries. We have to fight this ignorance. We have to rise and say, this is wrong, stop it. So you can differentiate between the tumor and the brain tissue. This is in the anterior horn of the lateral ventricle. And here I'm completing the opening of the foramen mondo. And you can see this is opening well. You can see that it is vascular. Here I'm officially opening foramen mondo. And I have to keep an eye on the structures there, which is the fornix, the column of the fornix. You damage it and the patient will have complete loss of memory for recent events forever. Here, taking the tumor out from the coronal plexus, the lateral ventricle. So this is the coronal plexus, this is the stereochoroidal artery. So I'm happy I've taken much more than I thought I could, maybe 95, 98% of the tumor, and that's in the ventricular system. Now what do? I put the direct. Okay, I've opened foraminal wall, but maybe there could be adhesions or a blood clot, so I have to put something as a precaution. So this is the external drain, which I keep it for a few days until I'm sure that there's no more radicals. Histology, Dr. Hassan,
How long do you keep that external drain?
a few days.
This is very interesting case. This is germinoma, as Dr. Ibrahim Sbeih alluded to. He did cervical food, but there was no evidence of tumor, so this is still stage 1. You can see this is a microscopic low power view. You can see very cellular tumor. This is what the germ cell tumor looks like. A lot of blood in the area. Again, you can see how the cells they are dark blue nuclei with the clear halo of cytoplasm, and there are some lymphocytes. I'll show you more. But this is typical of germ cell tumors wherever you go, whether in the brain, on the retroperitoneum area, or in the testis. This is what it looks like. These are small lymphocytes. You can see them. And these are the tumor cells. There's a lot of lymphocytes here. And these are the tumor cells. And you can see they are usually large nucleus with a prominent nuclei and clear cytoplasm. You can again see this is typical, large, clear cytoplasm, large nucleus with a prominent nuclei and in nest, and there's many lymphocytes. The lymphocytes usually sometimes give you a hint that this is a germ cell tumor. The other tumor that you can see lymphocytes in commonly is thymoma. So when you see something and you want to wonder if before the era of immunohistochemistry, this was really a very good helpful hint that we are dealing with germinoma. You can see this is another higher power. You can see how the nucleus large with clear cytoplasm, very vascular tumor, and you can see many lymphocytes in the background. Again, here you can see all the same thing. I take a lot of pictures because these nice cases rare, you don't see them every day. Again, you can see these are the tumor cells and these are the lymphocytes in between the tumor cells. Again, here you see mitosis in many times, and this is common in germ cell tumors, see mitosis. Again, you can see here other areas how the cells cytoplasm is clear. This is actually contain glycogen. I will show you by BS stain how it's positive by glycogen. This is BS stain, stains the glycogen. The red stain is the one that indicates that the glycogen. You remember I told you this clear cytoplasm, actually the cytoplasm contains glycogen, that's why it's clear. And this is one of the features of germ cell tumors. So this again BS, and you can stay strongly positive. When you see this before the era of immuno, it gives you a strong hit with the lymphocytes that this is germinoma. Now with the immunohistochemistry, it's becoming very easy and more definitive. We are not allowed to make diagnosis with the era of immuno. This is leukocyte common antigen. I want to highlight how many lymphocytes you can see. Many lymphocytes. Some of them they are probably will not be evident if you see them by H&E, but this makes them clear. This is now we come to the immunohistochemistry. How we will elaborate more in the immunohistochemistry. Dr. Ibrahim has mentioned some, but now with germ cell tumors, new markers are coming and more definitive markers are coming. This is called OCT34, and this is nuclear staining, and you can see mitosis here. This is strongly positive nuclear staining. When you see this is very likely to be germ cell tumor. OCT34 stains tumors, germinomas and embryonal carcinomas. This is OCT4, the same thing. this is the positive staining on the nucleus. You can see the clear cytoplasm. It's a nuclear staining, and when it is positive, indicates a germ cell tumor. This is CD117. CD117, the same as c-KIT, we call it. It was negative in this case, or it's weakly positive in some cytoplasm, cytoplasmic staining. It has some probably clinical, and this is the c-KIT cytoplasmic staining, and this is the c-KIT cytoplasmic staining. Indicates that this is also it's positive in germ cell tumor, but it's positive in other things. It's positive when there's thyroidase kinase enzyme deficiency or problem, and we use it sometimes for treatment, biological therapy. So it's not diagnostic of germ cell tumor, this immuno, but it's helpful for confirming the diagnosis and for embryological health. This is a plaque with placental leukocyte alkaline phosphatase, and you can see this cytoplasmic staining. I really like this stain. It's sometimes strong. Now people are becoming less and less interested with this stain because it stains other things like epithelial tumors. But the same thing with other immunohistochemistry markers. They stain sometimes other, but you have to take everything with the context. And when you see it with the context, I think it's a very good indication that this is germ cell tumor. Actually, this is another case. I had it recently. This case was sent to me from Dr. Ala Addasi. I don't know, he's not here. This is what from 25 years old male has a brain tumor, and he was called because they did pancytokeratin in one other labs, one famous lab. They did pancytokeratin, it was positive. He's 25 years old, and they called because of positive cytokeratin. That means that these to them epithelial cells, and they called metastatic carcinoma, and they stopped at this point. They ignored the presence of lymphocytes. It came to me as consultation. You can see so many lymphocytes there, and they are clear cells. If they looked really carefully in the histology, they won't miss this diagnosis. This is again the case. You can see how many lymphocytes. These are the tumor cells. It was cytokeratin positive. Cytokeratin positive are usually present in non-germinomas, like in embryonal carcinomas, in alpha, in yolk-sac tumors. So you have really, when you have pancytokeratin, you have to seek other immune markers, as in this case I will show you. This case has other areas that are spindle cells, and this is tumor. This is part of the tumor, and this is the tumor, and also forms glandular-like elements. This is embryonal carcinoma. So this is non-germinoma, germ cell tumor, non-germinoma. And this is very important to look at the histology. So it's very important to look at your slides very well, and to make everything with the context. Not to jump into diagnosis because cytokeratin positive to call it carcinoma, because it makes a whole lot of difference to this patient. You can see how these tumors form glands-like, but you can see very interesting things. Problem you don't see much. You can see globules in the cytoplasm. This is mitosis. You can see another globule in this cytoplasm. You can see another globule. When we see globules in cytoplasm with the germ cell tumor, we suspect highly that this is yolk sac tumor, because this is the secretion of yolk sac, the alpha beta protein. So what we did in this case, this is SILA4. SILA4 is one of the new immune markers that is used for germ cell tumors. It's positive in almost all germ cell tumors. It's like germ cell tumor markers. It's positive, it's nuclear stain positivity. You can see it here. And you can see it also positive in the spindle cells that we saw in this case. And now it's the preferred first line marker to call this is germ cell tumor. This is because sensitive and specific for germ cell tumors. This is a placental localized alkaline phosphatase in this tumor. You can see it's positive, the cytoplasmic staining, membranous staining. And this is alpha beta protein that I mentioned to you, the globules. And these are the positive. You can see they're strongly positive. So this patient has high alpha beta protein by immunostaining and by serum. This is CD30. CD30 is not specific for germ cell tumors, but it is used because it confirms the diagnosis, and it's usually positive in non-germinomas. And this is very helpful. So really, this is OCT34. It was negative in this area. I have the video. But I want to show you what we have markers for germ cell tumors. Dr. Ibrahim mentioned some markers, but we really have extensive markers now, because you have really to differentiate between one tumor from other. I think it's not present here. This is embryonal carcinoma, this is germinoma, and this is embryonal carcinoma, this is yolk sac tumor, and choriocarcinoma. You can see I have in my lab all these markers that are in the red. Well, I use them when really I need to differentiate between different markers. You can see the silophore that I mentioned is positive in most of the tumors, not in teratoma. This is teratoma, will not be positive. OCT 4 positive usually in, I use it for embryonal carcinoma and in germinoma. SOX2 is positive in germinoma, in embryonal carcinoma. The BLAB is positive mainly in germinomas, and the alpha beta protein is positive in yolk sac tumor, but we have another better stain for yolk sac tumor now. It's available also. It's called gliptan-free, and it is very nice and very important staining. So you can see cytokeratin. You can see cytokeratin that they depended on it in the last case. It's usually negative in germinoma, it's positive and strongly positive in other tumors. So if you really do cytokeratin, you're really going to do mistakes if you do it alone. I'll try to show you this video. This is a patient that came to me because of retroperitoneal tumor. I'll show you other areas of the germ cell tumor. You can see this is very big retroperitoneal tumor displacing all the viscous. He is young, about in his 20s, and I did for him fine needle and true cuts, and I did immunostaining for him, and this was germ cell tumor. Was to show you other areas of the germ cell tumors. It's a short clip. Thank you.
Thank you. Actually, I had a slide for these old markers, but I left this for you. So we finished, say, 11 o'clock in the evening, 7 o'clock from the morning, she must have MRI. No patients on a ventilator to leave the theater because of the excuse عشان نريح المريض. This is nonsense. This is medicine coming from Mars or other planets. There's nothing as such in medicine. It's a creation of mediocre surgeon to keep patients on ventilator because it was long surgery. It's utter nonsense. And you must have MRI the following morning, not a CT scan. The excuse is CT is better than MRI to show the blood. Utter nonsense. MRI is highly better than CT for the blood. So no excuse. MRI before surgery, MRI after. We want to know what have you done during the surgery, unless you want to hide something. So this is immediate post-op. You can see where we went. Tumor radically removed. I don't believe in biopsy at all. Marwan asked, do we attack both? I did not attack this, because once I confirm this is germinoma, there's no need to attack this.
Just do radio or whatever.
Yes, exactly. This is the rest of the pictures, because some of you may say that I have selected certain cuts. These are all the cuts. All the cuts, to show you exactly what you have done. And this is the patient, the very following morning. She had her external drain still intact, because I want to make sure that her hydrocephalus will resolve. All right, I opened Farah tomorrow, but you may have a clot, you may have adhesions, that may cause hydrocephalus. So this is the patient, no facial weakness, nothing, no weakness whatsoever. The drain is there, and this is for the nurses. Any nurses around? External drain is different from any other drain. It is a killer if you don't know how to handle it. If you put it on the floor, patient will die instantly, because all the CSF will come down, the brain will collapse, and the patient will die. We keep it at a certain distance, at a certain height. Either we open it continuously and drain at a certain level, or we open and close it accordingly. So, this is just CT to see the position of the external drain and that there is no hydrocephalus. This is the MRI again, showing you the radicality of excision. This is the patient just before discharge. This is our discharge summary again, I keep alluding to because we are in Farah Hospital, the only hospital who's doing this extensive discharge summary. And I'm happy to announce that our residents are very familiar with this. So they write excellent discharge summary nowadays. Everything is there. Every detail. And as I keep saying, that discharge summary starts with admission. So recommendation that we need to give radiotherapy, although we did radical excision. So we refer her for radiotherapy. For Farah Nasser, can you come here? Dr. Sam Khatib, Dr. Farah did radiotherapy.
This patient treated in 1913 in July. He received to the tumor bed with safe margin 45 degrees of radiation and 25 fractions. And all the time the patient was conscious, well oriented, and she did very well. And after that, we sent back to her doctor, and after that, we don't know what happened.
I will show you. So she had her radiotherapy, 50 degrees, 45 degrees over 25 fractions, no chemotherapy, just radiotherapy. And here she is. The same year, 2013, October 2013. We keep doing every 3 months. Every 3 months.
Okay, sir.
Hello.
Hey, may I ask a question? Why
Yes.
did you only do radio, since you were also alluding earlier that the combination therapy would be more effective as a treatment?
So because we have done radical excision, so one would be.
Yeah, but you're dealing with another tumor as well.
Yeah, that's exactly, because this is radio sensitive, very, very sensitive.
Oh,
Remember,
okay.
chemotherapy is less than radiotherapy. So this disappeared completely. There's nothing there with radiotherapy. No complications. October 2013, every 3 months. And then every 6 months, 2014. MRI photos. She disappeared into Iraq and came back 2016. Again, no trace of the tumor. She's doing well. 2017, February. Pictures. September 2017. Pictures. April 2018. Pictures. And just a few weeks ago, a couple of weeks ago, she came by and she was a beautiful girl, doing very well.
How much did she add in height?
She did not.
Not at all.
Because it was
Nothing at all?
not 1 millimeter.
Any idea about her school performance?
Absolutely perfect.
School performance.
Absolutely perfect, yes.
Sexual issues.
Started to develop some sexual. She started having a period, started on the cover. I will open the discussion just to finish with this. There is no tumor here. That's the latest MRI, and that's the girl. I think looking at her gives you the satisfaction of your life. And you did not make her life miserable with the shunt. You have done your job during surgery well. You have given her radiotherapy and followed her closely. That's the best we can achieve, and this is the satisfaction of a lifetime. Thank you very much.
She ended up with a smile.
Absolutely.
She's here.
Open, Dr. Ibrahimi.
Thank you very much, Dr. Ibrahim. Thank you very much, Dr. Ibrahim, for this really nice and comprehensive history overview. I just have a few comments, if you allow me. First of all, I would like to comment that germinoma, in most of the cases, they do not secrete beta-HCG. However, in 10 to 15% of cases, we can find beta-HCG, whether in the serum or in CSF. So this is the dilemma when we have germinoma and positive beta-HCG. Should we?
Usually it's a small increase,
Yes.
nothing.
Yes, the current recommendations, if it's more than 50 units per liter, we might consider re-biopsy for possible non-germinomatous component.
So
You know,
we
it
will
might
take
be
it from
heterogeneous.
50 to 100.
Yes, it's controversial. 50 to 1. We might biopsy the germinomatous component and not biopsy the non-germinomatous
So your
component.
comment is well taken that
Yeah.
if you suspect that beta HCG,
Is high.
it's better to go for biopsy.
Yeah, especially if more than 50. Yeah, another thing I'd like also to share you in answering our colleague's question why this patient did not receive chemo. Because this patient, Dr. Nabil, treated her in 2013. Actually, back then, most of physicians would treat with radiation alone. Now, 2 or 3 years ago, the interim analysis of the current Children's Oncology Group trial, the COG trial, ACNS 1123, it's still recruiting patients. However, they did an interim analysis and they found superiority for combination of
Yeah,
four
Dr. Ibrahim
cycles.
mentioned that earlier as well in the report. He mentioned that. That's
Yes.
the third conference. Yes.
So this is
The
study,
third.
the study.
That's
So
why
this-
I asked exactly. That's why I asked the
Exactly.
question.
But for this patient, Dr. Nabil, I agree with him. He treated
Yeah,
her in
that's-
2013.
Yeah, yeah.
Yeah.
This is
That's-
an ongoing study.
Ongoing study.
That's the reason I asked the question. Because
Absolutely.
he had mentioned that.
Yes, a valid question, absolutely. So what they do is they get 4 cycles of cis etoposide for 12 weeks, then we wait 30, we have to start radiation within 31 days. Their standard is, if the patient achieved complete remission radiologically to neoadjuvant chemo, to give whole ventricular radiation, 18 grays reduced dose. The whole idea of giving chemo is to reduce the dose and volume of radiation to reduce the neurocognitive effects and the endocrine effects on the patient. We give 18 grays, whole ventricular, then boost 12 grays. The total will be 30 grays. If less than CR, but the residual is less than 1.5 cm, we give higher dose, 24 grays whole ventricular, then boost to 36 grays. If the residual is, this is my question to you, if the residual is more than 1.5 centimeter, we might consider a second look surgery. So here in some cases, especially for nongerminatous, because it's less radiation sensitive and less chemosensitive, the role of second look surgery is even more important. A third point here is, yes, I totally agree with you, Dr. Sbeih, that whole ventricular radiation is the way to go. However, in a case like this, I would also include the suprasellar cistern and the prepontine cistern, all the way down to the foramen magnum, because whole ventricular radiation will not cover the contamination around the parasellar location. So this is just an important point for any trainees, if anybody in radiation. So sometimes whole ventricular radiation alone is not enough. We have to include the suprasellar and the prepontine cistern, exactly. Yeah, that's it. Yeah, thank you so much. Thank you.
I wanted to make a point tonight that I want to finish in below 1 hour, and we did.
Yes.
Because I want to really finish in 1 hour.
I felt it.
Yeah, so we did well. Any questions? Any comments? Dr. Ahmed Jamil is a budding surgeon. Budding يعني budding.
دكتور بدي اسال is it possible يعني لو %0.1% انه يكون the other tumor is another tumor يعني why did you take the risk انه طب I'm already there everything is open at least biopsy اخذهم على جنب هذا another
Fair enough question. I think that's a fair enough question.
وفي سؤال ثاني بعد اذنك دكتور هلا بالنسبه للراديشن في period time هو حكى الدكتور انه after 31 days within 31 days بس احنا as neurosurgeons مشان السكن مشان الهيلينج يعني في عندنا time period نقول now we can start the
Once the
radiation.
skin has healed, which is 7 days, you can give radiation. Back to your question. If you are sure, why should we take a biopsy? If you are in doubt, take a biopsy. But then I'll just take you through the biopsy. What are the drawbacks of a biopsy? In the best of hands, the complications of biopsy is 1 to 2%. Infection, hemorrhage, whatever. The most important those are the positive negative and the negative positives. The amount of specimen that you take and the metastasis that can occur across the thing. So you have to wait it. But as you said, if you are in doubt, take a biopsy.
Fair enough, yeah. Fair enough.
Any questions? Please.